My name is John McNeill. I want to thank the other members of the team, Matt Crivello and Dev Sen, from the Electrical and Computer Engineering Department at WPI in my research lab. Professor Yitzhak Mendelson is in the Biomedical Engineering Group Department at WPI. Raymond Dunn and Kelli Hickle are doctors at the UMass Medical School. Dr. Dunn is the chief of the Plastic and Reconstructive Surgery Department, and Kelli is one of the residents in his research group. So I'll go over background and motivation, system approach, our experimental results, and summarize at the end. Caution, there are a couple images of a pressure ulcer wound and an animal experiment that people might be uncomfortable with. I'll give you a warning before they show up. So we'll start with the need for pressure ulcer prevention and current methods of preventing pressure ulcers. The next slide has a picture of a pressure ulcer. It's a nasty, nasty wound. It's painful. You can see that muscle and connective tissue underneath the surface of the skin can be exposed. Healing of the pressure ulcer takes several months. This is a timeline about 2 months apart in each of these pictures. During the time it's healing, there's a tremendous risk for secondary infection. About 3% of people who get a pressure ulcer end up dying from a secondary infection unrelated to what initially landed them in the hospital. As I said, if healing happens, it takes several months. In a compromised patient, for example, someone who's older, it may not heal at all. $11 billion annually added to US healthcare costs, and as the population ages, we'll see pressure ulcers more and more of a problem. They're also known as bed sores or decubitus ulcers, and rather than try to heal this wound, let's prevent it. We need a compact, low-cost prevention method for patients in 3 different types of use cases: in a hospital setting, confined to bed at home, or with limited mobility in wheelchairs. The cause, localized pressure. So a location in the body that has a bony prominence, say the heel, for example, or a shoulder blade. On a bearing surface, the localized pressure will restrict capillary blood flow. It's about 30 millimeters of mercury is the threshold where these capillaries start getting closed down. If that happens for a long enough time, this tissue is deprived of oxygen and can lead to tissue necrosis, tissue death, and the formation of the pressure ulcer will begin. So the current prevention method is to turn the patient every 2 hours. This is a classic graph from some very early work that's done showing pressure on this axis and hours of continuous pressure here. So you can see 20 to 30 millimeters of mercury. The tissue can tolerate that essentially indefinitely. And then the more pressure there is, the fewer hours of continuous pressure are recommended to prevent a pressure ulcer. But as has been pointed out, this graph that people have been using to justify this 2-hour turn protocol forever wasn't based on any kind of clinical trial. It's just sort of a folklore thing that people have been using, and it sort of works, but there are disadvantages to it. It increases the caregiver workload. If the patient is moving on their own, many of the turns are unnecessary and just disturb the patient who may be trying to rest. And for obese patients, it's difficult to turn them. There's a risk of caregiver injury, and you don't want to turn them if you don't have to. So the opportunity for prevention comes from knowing that there are locations on the body where the bony prominences are close to the surface that we can monitor depending on if the patient is lying on their back, on their side, or in a sitting position, for example, in a wheelchair. 90% of the pressure ulcers you see will be at one of these hot spots. So depending on the setting, we know where these hot spots are going to be, and that opportunity for prevention underlies the approach we're taking. So our approach is threefold. We're going to use a wearable sensor patch between the bony prominence and the bearing surface, measure the local pressure at the location at risk for the pressure ulcer, combine measurements from multiple sites in a system, and then monitor pressure versus time and alert the caregiver or the patient if there's a pressure ulcer risk, so you can move and relieve pressure on the location. So the desired attributes for this system, we need it to be low cost, both the fixed costs of any monitoring equipment and also the per use costs for the sensor patch. It's preventive. Again, getting away from the idea of wound healing and going towards wound prevention. We'd like it to be applicable in as many settings as possible: hospital, home care, or for someone who's partially mobile in a wheelchair, and multiple options for communication as well. To a caregiver, a monitor; for a doctor, accessing data over the web or in a cloud application; and for the patient themselves, if they're mobile enough or being cared for in the home, a smartphone app type display. So the system has those three parts to it. The work I'll be talking about is on the device part of the system. So what we're looking for on this sensor patch ultimately will be an autonomous, wearable, wireless patch. We'll have some kind of pressure sensor, temperature sensor. We probably will be sensing relative humidity or moisture as well, although that's not in the work I'll be presenting today. And again, the nice thing is we're measuring the pressure directly at the site where the problem will be occurring. It needs to be small size, comfortable wear. We'd like a wearable duration of about 3 to 7 days, depending on the setting for the use case. So I'll be presenting some of the experimental results from a prototype we've done for the sensor electronics, and I'll be summarizing work that we presented at an earlier conference, and then the novel work here on a flexible wired prototype. So the sensor we're using is just an off-the-shelf force sensor, and we're normalizing by its area to get pressure. The way we're doing the measurement for both the force-sensitive resistor and the resistive temperature detector is to measure the resistance, encode that in the duty cycle of a clock, and then have that measured by a microcontroller. The challenge here is calibrating the pressure measurement sensor. Shown here is the characteristic of conductance on this axis versus force on this axis. When we normalize it to pressure in millimeters of mercury, it's this yellow area for the range of pressures that we'll be measuring in this application. So the red here is the nominal characteristic. So the bad news is it's nonlinear. The good news is we can model it with a 2-parameter fit. But the bad news is there's a lot of part-to-part variability as well. So for measuring the resistance, we need to linearize this characteristic, but then also account for this part-to-part variability with calibration. So here's the measurement circuitry we're using. In this simple application, we're just using a 555 timer. We've got a reference resistor, and then our sensor here is in parallel with a very large resistor, so the clock doesn't shut off if we get a very large value for this force-sensitive resistor in the case of 0 force. The duty cycle is just the fraction of the high time as a fraction of the oscillator period. And the nice thing about using the period is it's determined only by the resistance ratio. This capacitor affects the clock frequency, but not the period. So as long as we have a well-characterized resistance for this reference, we can use this equation to work back to the value of our force-sensitive resistor. And then working back from that, we have this equation that we'll use for linearizing the characteristic from the duty cycle that we measure to the applied force, and that'll give us the pressure. So the calibration parameters are the R naught and the exponent X for the force-sensitive resistor. So here are some measured results for 4 different implementations with 4 different force sensors. The uncalibrated performance is shown here using the nominal data from the red in that previous plot. So you can see there's, in addition to the part-to-part variability, there's also kind of a systematic bias away. It's still within the limits of acceptable behavior, but you can clearly see the need for calibration here. So again, looking at the calculated pressure as a function of the applied pressure, after calibration, we're pretty linear. You can see looking at the deviation from linearity, we're within plus or minus 3% of full scale. And we're using a 2-point calibration at minimum and then at about 2/3 full scale. And the calibration procedure is also implemented in the microcontroller. So when we set it up, we just apply these two known forces, and it'll calculate the parameters to use. So the next step was to implement it on a flexible prototype. So shown here is on this flex PCB, flex material. It's 3.5 centimeters in diameter. That's the size of an electrocardiogram patch. And again, this is just electronics. We've got another group working on skin-compatible adhesives and materials. So here's our sensor, the pressure-sensitive circuitry, the temperature-sensing circuitry. Again, it's implemented in wired form now. We want to make sure that the data we'll be getting from this shows what we need to justify going forward and doing the development for the wireless version. So the following slide has a picture of the sites we instrumented in the animal experiment. So this is a pig. It's the animal model that we're using for a separate surgical procedure. Let's see, here we go. So this is the pig's head. You can see the ears here. Ultimately, the pig is turned over on its back during the surgical procedure. So these points along the spine, the back of the head, the top of the vertebrae, and the bottom vertebrae are 3 sites that we instrumented. Again, it's a wired implementation. You can see here we've just attached the patch with just a clear skin-compatible tape. So then after we attach the sensors, the pig is put on its back for 7 hours during the surgical protocol that was done as another part of the experiment. But this is actually a good model for one problem use case where pressure ulcers happen is when somebody is in surgery for a long time and they're immobilized on an operating table. So here's the experimental data. What we're looking at is on the vertical axis on the top plot, pressure in millimeters of mercury as a function of time. And the time goes from about 11:30 in the morning to about 6:30 at night. So during the first 20 minutes or so before the sensors are attached, that's kind of a convenient zero pressure control. Sensors are attached. Sensor 1 had some mechanical intermittent issues, so I'm not showing the data here. But when it was operating, it looked pretty much the same. You can see there's a lot more noise in sensor number 3 due to the nonlinearity. We chose to have the region of worst signal-to-noise ratio up at the maximum pressure where we're over the threshold and we don't really need to know the pressure that accurately. So what's interesting to see is that every 90 minutes or so, the pig was moved as part of that surgical protocol. And what you can see is that pressure is relieved where sensor 2 is, but it's not relieved on sensor 3. So the need to have multiple sites instrumented is shown from this data. We're also looking at temperature data. Here there wasn't as much going on. The surgical protocol required the animal's body temperature to be stabilized by a thermal blanket at 42 degrees C, and that's pretty much what we measured the whole time. So in conclusion, we were able to verify that this sensing approach will sample the contact pressure at a high enough rate to resolve the pressure relief events. And we also get enough resolution to be useful in developing the system algorithm. And what's also interesting from the multiple site instrumentation is that the relief in pressure is much less pronounced or actually absent in the results between sensor 3 and sensor 2, showing the importance of having multiple sensors that correspond to the individual contact pressure in each at-risk point. So just because you're moving the animal, it doesn't mean you're necessarily relieving pressure at all the places that are subject to a risk for a pressure ulcer. I'd like to acknowledge funding from the UMass Medical School WPI Collaborative Seed Funding Initiative that supported this work. Also Bill Appleyard at WPI, who assisted with sensor fabrication, and Heather Tessier from the UMass Med School, who assisted with the experiments.
Thank you.
Thank you.